Victoria, for those that haven't come across you online, introduce yourself and tell our listeners what we're talking about today.
My name is Victoria Reinhartz. I'm the founder and CEO of Mobile Health Consultants Incorporated, which is an organization that helps to empower EMS and mobile integrated health teams across the nation.
When I hear of paramedics, I'm thinking, all right, they're mobile. For me, the question is, how mobile is mobile?
Yeah, so you have the right idea. So we really do mean mobile, and mobile can mean different things to different people. For some people, we think just remote, especially now in this day and age with telehealth and things. And so, it's going to depend on the community and on the program. But what we're talking about here is, there has been an oversurgence and overuse of the 911 system. So we know that we have an access to care issue, and we know that patients are calling 911 and being transported to the ER or visiting the ER unnecessarily for chronic diseases because...
More so now with COVID and things, or this has always been going on?
So, this has been something that we've been dealing with for years, right?
Yeah.
The discrepancy in the true access to care issues that minorities and underserved populations are experiencing are just highlighted probably more so over the last year with the pandemic. But, this is an issue that's been around for years. And so a lot of EMS teams across the nation and also fire-based teams and health systems are launching what we call community paramedicine programs or mobile integrated health programs. And so these are utilizing paramedics, providing them some additional training in things like chronic disease and social determinants of health, and sending them out into the community to address those community needs and increase the access to care. And so when you have a base of a community paramedic to meet this need, you can also integrate other healthcare professions, and then that becomes a mobile integrated health team. And so it's really what it sounds like. And we are utilizing vehicles, and these are emergency response vehicles that are run by EMS personnel as the backbone, but also other healthcare professionals. And we actually go visit patients in their homes on a proactive basis and on a scheduled basis in order to identify what their disease and social needs are and how to resolve those and to break this cycle of calling 911 and ending up in the hospital.
The 911, that's so damn expensive to get people into an ER. I imagine that the pencil pushers are saying, let's find a way to decrease this. But from a healthcare side, are there ideas that you would rather see happen preventatively versus in the emergency room? I'm going to guess that you're saying, no, it's not just cost related. Is that right?
Well, I think that if you want to get people's attention, you talk about costs, right?
Yeah.
Because you're right. The money makes the world go round. And the good thing about an approach like this is that any way it's implemented, you're going to have an impact on the bottom line.
Yeah.
And you're going to have improvement in health outcomes. At least that's what we are finding across the nation. So, there's several hundred different mobile integrated health and paramedicine teams across the nation, and they look differently in every community. So, we have some programs that are falls focused and they do home safety assessments and things. We have some programs that are more like hospital on wheels and do, everything from imaging to acute care management in the field. And then we have programs that are more chronic disease focused. And so when you talk about prevention, I feel incredibly passionate about this being a solution to not only resolve the access to care issues, but to focus on prevention, right? That's the epitome of what we do is we see the patient proactively before they have a 911 call in order to address their disease, address their medications, address those socioeconomic issues in order to, bring their prevention focus to the forefront.
So my question is kind of a moot point. It's not like what's better, 911 care or some other care. We're talking preventative care, so that question never even comes up in the first place.
Correct. Yeah, that's the idea, is that we utilize this as a preventative care model so that you eliminate the access to care issues. We'll come to you. And so by doing that, we can reduce the 911 utilization, we can reduce the number of ER visits, and we can reduce the number of hospitalizations.
In Grand Rapids here, I know that the fire department is the first respondent to any call. Is that true nationwide, or is that different in different states?
That's going to depend on, what the first responder system looks like in that state. And so, when you call 911, there's a dispatch section of what we think about as public safety. And they are going to ask specific questions, and they're going to route the appropriate team to the location depending on, how the caller answers those questions.
In Grand Rapids, the fire department will go for everything, a twisted ankle or things like that. But in some states, they do it differently. Well, in any community, they probably do it differently, right? They might send out the EMS more and things like that, depending on what they have set up.
Correct. That's absolutely correct.
So, Victoria, are you a teacher or a business person? I saw on your profile how much you love to teach. How did this start then? Did this start as a business venture or a teaching venture or neither?
So in my heart, I'm both, I think. And this was a crazy idea, if you can believe it, right? All great things start as a crazy idea to somebody. So I have been a faculty now for almost 6 years at Lecom School of Pharmacy in Bradenton, Florida. And I knew that I wanted to continue to practice, so that's why I accepted a practice faculty role. And I knew that I wanted to do something with underserved populations. And so I actually originally started within the Department of Health here in Manatee County within their tuberculosis clinic.
Why'd you want to help underprivileged?
Well, I had my first job coming out of pharmacy school was with Target, and I was a pharmacy manager for them for several years in Sarasota, Florida. And I found that a lot of my patients were really positively impacted over the years that I was with them. And I found that I really loved the concept of medication therapy management, and I was having a lot of success in that area. But I knew that Sarasota, Florida is not an incredibly poor area.
It's not.
It's not, correct. Yeah. So there's a lot of money in Sarasota, Florida, and
Gotcha.
I really felt like, yes, I'm having success with these people who have adequate resources.
Right.
But I felt like my skill set was not being utilized for the population that most needed me. And so that was a primary goal when I took the faculty role was, figuring out how do I utilize the skills that I have for a population that really would benefit a little bit more.
Did you think it would be more of a challenge? Were you unchallenged with the people that had ways to, buy their way out of something or buy their way into something? Or was it something in your heart?
No, I think...
This intrigues me because I don't have feelings like that.
No, I think it was both because, I was a new graduate, right? And I learned a lot about the concepts of pharmacy management. I learned a lot about clinically, managing medications and the big issues that come up. And I learned a lot about what was, statistically something we learn and what's clinically actually relevant to my patient, right?
Right.
And so I think it was a really great first opportunity to learn. But, I found that over time, the patients that really appreciated me most were the ones that were struggling in some way, right?
They appreciate you more. That makes sense. I can see that.
Yeah. So, the elderly who were completely isolated and by themselves and didn't have support and were were having loss of eyesight and couldn't fill their pill box and needed my help I found that those were the interactions that really were most impactful to not only to the patient, but to me as a professional. And so that's where I started to realize, the patients that have access to everything they need are not the ones that really need me.
And they maybe don't appreciate you as much then.
Yeah, sometimes it can be tough for people that are used to having really quick and efficient access to everything that they want. But my patients in Sarasota were fantastic.
They're probably not listening, Victoria. Come on. come on. What are the odds of them turning into a pharmacy podcast? Let's go after them.
I don't know.
Their big gaudy jewelry, they lay their purse on the thing and their diamonds are knocking all the counter stuff over.
Well, we can tell definitely that you've owned a pharmacy for a while. So yeah, there is a lot of entitlement, but I think it's anywhere,
Sure.
right?
Yeah,
so
exactly. What's your first connection then to saying mobile?
When I was a faculty and I started within the tuberculosis clinic, I kind of was brought into as a consultant to figure out, they had gotten a grant for establishing, a mobile team or a paramedicine program. And they brought me in to say, what do we need from a medication side? And this is where, our group at the Department of Health here in Manatee started to really explore, okay, so what does this look like? Does this look like the paramedics drive home to home? Does this look like we get a bus and drive the bus to specific neighborhoods? And, honestly, there is no one direct answer, and mobile can look different for every single community. So we have communities where, they do a bus type format where they have primary care providers on the bus and drive the bus to a needy community and sit there every Monday, Wednesday, and Friday. We have, programs like ours where we send paramedics and licensed clinical social workers and pharmacists out to individual homes through, SUV type vehicles. So it's different in every community, and mobile is, defined around how do we meet that need.
Yeah.
It's not predetermined based on, something prescriptive.
While you were still in the early stages of your career, you had already seen mobile taking place. It's kind of foreign to me. I mean, when I was a kid, I used to go to the bookmobile.
Yeah.
Do you have bookmobiles?
I do, yeah.
Big old
Heck
van,
yeah,
it's
man.
oversized Winnebago, and you go in and find books. And they were always like, probably the same books. We probably read them over and over again.
Yeah, but that was the best day, right? The book fairs, the bookmobile, those are the best days.
Oh, those were
in
great
school,
days.
Right? This concept around mobile too. When we look on the news, we're seeing things constantly, like Pharmacists goes above and beyond and delivers medication to patients' home, or pharmacist. I just saw an article last week about a pharmacist who was going out in the middle of the night to patients' home to deliver vaccines because he didn't want it to go to waste. And it's pretty consistent, I think, when you're in healthcare that you have a patient with an issue and you're like, I could solve this problem right now, right? Like if I have a vehicle, I know what needs to be done. I could go visit the patient, or I could drop off, whatever the paperwork to the Medicaid office or whatever it is that needs to be done. I think we've all probably in healthcare had that moment where you were like, if I were mobile, I could solve this problem right now.
If it didn't have to do with mobility, it may not even be a problem you're seeing. It would already been taken care of. I mean, there's financial stuff in
Correct.
that, but because of the mobile issue, that can often be the problem that you say, oh, it's a mobile issue, right?
Yes. And also, there is the qualitative component that you get out of being mobile that you don't when you're contained within, a four walls or in a location. So, you get a lot greater insight into a patient's home life. What their true situation is. You get a better idea of, how they're able to navigate their home, whether they're feeding themselves, the types of resources that they have within the home. And so that can really, influence and impact your understanding of what do I need to do to meet this patient where they're at.
I even do that in the pharmacy when I'm there, and you're sending people home with like 8 medicines, and they ask you a question and you're like, oh, can't believe I'm just sending this patient home with this. Because if they had that question, it's like, this isn't off to a good start. But you don't see any of the home dynamics on top of that. It's like, oh my gosh.
Yeah. And there's pieces specifically with the medication that can really be catastrophic. When you go into a home and you're giving them, 8 new medicines today because they're being discharged from the hospital.
Yeah.
But you walk in and there's a whole shoebox of pills
Right.
that they're, digging out of every day. And they, the first thing they're trying to do is dump the 8 new ones into the big shoebox with all the old ones. And there's just so much room for error. And it's huge. Yeah.
So you see this, and I'm trying to find the link finally that says you now have made it your own business versus seeing it and maybe helping others. When was that transition then?
I started working with the paramedicine team here in Manatee County. Our EMS chief and I realized that, the benefit would be to actually launch the pharmacist and send the pharmacist and the paramedic together into the home. So we've been doing that now for several years. We actually published last year, we did a cost benefit analysis of, how much does it take to run our entire program? And then what is the difference in system utilization and reduced costs for our patients? And so we realized that, there really is huge benefit on a cost level and outcomes level for this model. And I kind of fell in love with it. We knew we were making a difference.
Yeah.
We knew it. And so, in fact, we had such good success within the first year that the county actually expanded our program.
Gotcha.
And so, we were really detailed with keeping track of, outcomes and what was happening to our patients and collecting data. And so at the end of 3 years, when we actually crunched the numbers and we saw how dramatic the difference was, I think that was a shock moment to all of us, really.
Is that right? That's cool.
Yeah. So for every $1 spent on program implementation, we realized that we saved $4.02.
I imagine that you're targeting somebody who you thought somehow they were going to end up in the ER within the year or something, right?
Correct.
How'd you know that, from past trips there or something, or?
Yeah, so patients get referred to us if they have called 911 more than 3 times in 30 days. And so then they get enrolled with us and we start seeing them on a regular basis.
Wow.
And then we try throughout their time with us to set them up for success. So identify any of the problems, resolve those problems, reconnect the patient into care, do a lot of education, connection to resources, communication with their physician team, set them up for things like home health, get them insurance, identify and resolve all of the drug interactions and side effects and the nastiness that can happen with the medications.
Yeah.
And so we resolve all of that. And then when the patient is ready, and if they've met the goals that we've identified and set throughout the program, then they graduate from our program. And then what we do is we track afterwards, what is the change in pattern of their prior utilization versus now? How often are they calling 911 and are they having hospitalizations still?
Do they have a bailout number? I imagine they call, like, instead of 911, it's like, don't call 9. I mean,
yeah,
they must have a bailout number, right? Because they're probably in the habit of calling somebody.
Yes. And so that's one of the very first things that we do, right? As we start to identify all of their issues, we give them a cell phone number. And so they call the paramedic team if they are starting to feel unwell, right? And so we have a discussion about what's truly an emergency and what's not, but we go through the symptoms of their diseases. And, we say if A, B, or C happen, instead of calling 911, call us. We'll come see you, right? So in an hour or two, we'll come see you and we'll check you out and we'll try to, resolve what's going on for you.
Reminds me of my siblings, like, don't tell mom.
Well, yeah, in some ways it is, right?
Shh, don't call mom.
In some ways it's, and I won't say, Mike, that we don't have patients that are stubborn. We have patients that will visit them and then we'll leave and they'll turn around and call 911, right? If we make them mad maybe or something.
Yeah.
But yeah, so we've done this model. We after our first 3 years, we did our study, and I realized that we've had this incredible success, and I feel passionate about this model, and I think it is an excellent use of our skill set as pharmacists. And so that's where the business piece came in, was I felt like I just have this calling to, be available and help to provide not only direct patient care services, but also clinical education for teams across the nation.
In your local area, Victoria, did you turn it into your own Were you getting paid separately, or were you with an organization, the hospital or whatever, getting paid?
No, so I donate my time as faculty. So when I started the paramedic program in Florida, and so we really started to, have the pharmacists go out with the paramedics. We would do that 2 to 3 days a week. And that was my time as faculty. So that's why it was so important for me to be practice faculty.
Will it always be set up then as a faculty position across the nation, or do you have any thoughts of saying, no, here's how somebody could do this as a job not associated with a health organization kind of thing?
That is my long-term goal, is to teach teams how to incorporate pharmacists when you don't have a pharmacy school nearby, right?
Gotcha.
Yeah, so we were able to do a pilot program because I had, a faculty role and was able to donate that time, right?
Yeah, right.
So I was getting a paycheck, but my paycheck was from the university.
They're kind of like paying you to test it almost.
Correct. Yes. So my clinical hours were being paid for by the university. But again, that was part of the reason why we did a cost benefit analysis, is to show that even if you paid a pharmacist full time,
right,
if your program is focused on disease management and community risk reduction, that it is by far, pays for itself in the terms of, including a pharmacist on your team. Now, most teams, are not going to need a full-time pharmacist. And so that's part of what I do also, is educating them about, which patients are going to need pharmacist intervention, which patients are likely to have the most medication challenges, and how to possibly incorporate pharmacists for, ways to increase revenue as well.
What's the most that you would ever have sent to a house? How many people?
Really 2 to 3, depending on what the individual patient's needs were. If you needed, if you had a lot of social issues and a lot of chronic disease issues, then maybe 3, right? You might send like a social worker, the pharmacist, and the paramedic, or a nurse and a paramedic, or, right? So it kind of depends on what the patient's individual needs are. And so I think 3 is the maximum that we have ever done. In COVID, the maximum is 2. So since the pandemic, we have maxed it out at 2 in a person's house.
Do you make use of any of the video things? Like, have you ever been along, like you've had 2 of you and the third person is, on a screen being carried by paramedic A, who's letting them talk to this other social worker or something like that?
Yeah, so the telehealth piece is really valuable in the terms of mobile integrated health or paramedicine. So we have teams across the nation that are playing a huge role within telehealth. And so what that would look like is the team goes into the home, they help set up the telehealth device, or they actually in some situations run the telehealth device there while the telehealth visit is occurring, right? So you might have a physician or a nurse practitioner that is on the telehealth device, and in the home you have the patient with the paramedic or with the social worker. The advantage to having the paramedic backbone to these programs is really because, so much of disease management is physical assessment. And, if I go into a home by myself, Mike, and I say, I think the patient's having a heart failure exacerbation, the physician, is like, okay, Victoria, well, that sounds great, but I need a physical assessment, right? And that's not your specific training area.
Right.
But if I'm there and the paramedic's there, and the paramedic can do the physical assessment piece, and then I can say, and here's his other med history and what the other medications are, and here's the medication that would fix the current problem.
I gotcha.
Then you have an extremely complementary skill set for a physician or a nurse practitioner on telehealth.
My mother-in-law, God bless her, my favorite mother-in-law, I have to say this in case she's listening sometime. The odds of her listening to this would be 10 times worse than someone in Sarasota listening to this. But anyways.
I have a favorite mother-in-law also. Yeah, I have one.
My siblings-in-law, I guess my wife's siblings, say, well, we bought mom this, but she's just not using a tablet with Facebook or, a Kindle with, books on or something. It's like, she's got no interest, and so a lot of these people, why would they want to get into this stuff 10 years left of their life or something like that? They don't know the right side up of a computer pad.
It's true. And that's the issue with telehealth, is that if these people could independently navigate telehealth and could independently navigate the internet, and they had access to all of that technology and knew how to utilize it, then they wouldn't be constantly calling 911.
They would learn it before they pick up the phone and dial 911.
Yeah, well, they'd be able to probably navigate the healthcare system. And so, so telehealth without a strategic plan for how to set that up successfully is not by itself or independently the answer to the access to care problem.
I was interviewing Neil Smaller, a pharmacist out east, a couple weeks ago, talking about the COVID thing, and he said this was not done correctly. You needed to take the over 75-year-old people and say, look, show up at your closest high school, bring your ID, we'll take care of you. You're telling these people to go on and sign up online and maybe even a double password, where they get texted their code, and then it's like, they don't know what the hell's going on with that. And this is very stereotyped, but the age of the people that can figure that stuff out are not the people that need the shots then.
Yeah, no, you're right. And so again, that's just one more way of how the pandemic has highlighted this population that really is not getting access to what they need. And, there's things like remote patient monitoring and stuff too, where paramedicine teams and mobile integrated health teams have been really instrumental for, going in and setting up remote blood pressure devices and scales and things so that we can collect data on patients and identify when they're having an acute issue or maybe aren't taking their medicine and things. But again, the patient's not going to know how to set all of that up most of the time.
One of my guests, we were talking about having like Amazon Echo there or something like that, and just saying, good morning, Sally, and then waiting for Sally to say good morning. And if she doesn't say good morning, something could be wrong there. It might just be that the damn thing's unplugged or something, but it could be that there's bigger issues. But sometimes it's as simple as that, because if you don't make it that simple, well, then you got problems. If it's on a phone or a pad or something, it's like, well, they probably just couldn't find it.
Yeah, absolutely. No, it's been really incredible. And, CMS is finally piloting what we call ET3, which is emergency treat, triage, and transport model for EMS, which allows for possible payment even if you don't transport the patient to the ER. So in that sense, the world of EMS and pharmacists are similar. As pharmacists, we don't get paid unless we dispense a product, right? And in EMS, they don't get paid unless they transport a patient to the hospital.
They don't get paid unless they transport a patient?
Correct.
I didn't know that.
Yeah.
Is that across the board?
Yeah.
I didn't know that. You'd think that they would show up and wrap an ankle or something like that. I never knew that.
Yeah, so that's why this is such a huge initiative, because this is for the first time exploring payment for either transporting the patient to a more appropriate location, like an urgent care, or, a dialysis center or whatever it is that's caused this acute issue that we're dealing with right now, or, triaging them in the home and setting them up with a telehealth visit right there in the home.
Oh, so they don't even get paid if they go to like something short of a hospital. Like they don't get paid if they go to an urgent care center or something.
Correct.
I didn't know that.
In fact, that is not protocol. Like there is not, prior to this initiative, there are not nationwide accepted protocols for transporting patients anywhere other than the ER. Yeah. So that is not an accepted use of EMS historically. And so now this is huge in that sense that for the first time, we are going to empower these teams to utilize their skill sets in the home to transport the patient, if necessary, to a more appropriate location and still get compensated for that time.
It almost seems like there wasn't enough incentive for this thing to change. I mean, if the ER gets paid for having a patient brought there, and if the EMS only gets paid for having a patient brought there, it almost sounds like doing anything short of that was not profitable. So why would you start a program like this?
You're right. And I think that's why it's taken as long as it has. And so many of us have been starting programs like this and pushing for programs like this because we see the difference that it makes. And we know that overall, this is the direction that healthcare needs to take, and that the same system is a broken system. And so, yeah, it really is completely upending the world of EMS as we know it, and in a good way. Right. And it's just like pharmacist services, right? So how long have we known that it's,
right,
what's up here in my brain
right,
is what you need from me as a pharmacist, more so than to dispense another pill to you that you probably don't need.
I'm trying to think of the winners and losers in this. And I'm thinking that gas companies and tire companies may not be winners in this ever. They always want to see vehicles and things on the road and so on. Short of that, though, the EMS, they pretty much want this across the board. Are there any people in the EMS community that would be fighting you on this and saying, Victoria, this is good for you, but stay away from this portion of the business? Is there anyone that you think would fight this system of improvements, or at least as what you see as improvement, and I would tend to agree as improvements?
I think anytime that there is change, it can be scary to people. Right?
Yeah.
So just like there are pharmacists that say, nope, I don't want to do MTM. I don't want to get involved in managing that disease. I
right,
have this skill set. I've been doing this for 20 years and I don't have any interest in learning, how to do that a different way. So just like you have that in our profession and people that are resistant to change, sure, sometimes you might have that within the world of EMS or in fire-based systems. But I think that a lot of EMS teams and paramedics are realizing they see the same patient over and over, and the issue never gets fixed. And, you ask a good paramedic and they'll tell you when they leave a patient's home, yeah, we'll be back there next week. We'll be back because this patient doesn't have what she needs, or he's definitely not stable, or his condition is not controlled. And I know I'm going to be seeing him again next week. And it wears them down. And so I think that, overall, more and more first responder teams are realizing that a model like this is absolutely necessary.
They get screwed a lot of times, right? They probably know that we can't bring Mrs. Smith again to the hospital. We were just there 4 days ago, but they probably can't just ignore her call. So they then go there and it's a money loss for them because they have to check in on her and so on. Yeah.
So, if the patient wants to go to the hospital, then they take them to the hospital.
Oh, I see. It's not really their call.
Yeah. They can tell the patient, you're not meeting any criteria that would cause me to say, yes, you need to go to the hospital.
Yeah.
But if a patient is complaining of, A, B, and C symptoms, they will take them.
Yeah.
Yeah. So, when you talk about teams that are, or is there anybody that is against this model, anytime that there's change, you have to think about new things, right?
Yeah.
Like, does our software need to change?
Right.
Does our training for our teams need to change? Do we have to revise our liability policies and reevaluate that, right? And the answer to all of those things is yes. All of those elements are going to have to change to meet the need. But, if we look at 2016 was when my program in Manatee County was started by our EMS chief. And, I think at the time there were like 15 or 16 programs in Florida and maybe like 60 nationwide. Now you're looking at, I don't know, several hundred, 300, 400 maybe across the nation. So more and more we're recognizing that this is definitely a successful model.
So a pharmacist is listening to this, Victoria, and is it way jumping the gun for them to say, I'm going to call Victoria and hire her for her services because she's going to teach me how to, maybe enjoy my job a little bit better because I'm doing something different and maybe more impactful and things like that. B, I want to make money on that. Or are you more like getting hired by a city that you'd come in and sort of be the consultant for like raising everybody up in this program, the EMSs, the fire department, the city to pay for it, and the hospitals and so on? What role do you see yourself playing, or are you playing?
So right now, really at this time, my services are geared more towards EMS entities, so cities or private ambulance companies or, fire-based teams or health systems that are launching a team because, I have the know-how to, support them from the beginning and help them create a program that is going to be structured in a way that is meaningful, that allows them to track the appropriate things, and also includes the disease and medication management piece, which is one of the reasons why our team has been so successful here in Manatee County, Florida. Now, that being said, I do feel that in the years coming, I probably will need to create a training program for pharmacists that are looking into some sort of arena within community health and doing some sort of mobile health care because, again, the model is spreading. We know that we have more and more programs being established across the nation. And I would say the number of people contacting me in general to say, how can I get a pharmacist, is definitely increasing. And so there is room for this, in years coming for pharmacists.
Groups are calling you and saying, hey, I see what you do as a pharmacist, and we're thinking of this, but how would I get a pharmacist on my team for this?
Correct. Yes. Yeah. So it's really exciting. And, I think that it's part of that, age-old battle as pharmacists where people are like, I'm sorry, wait a minute. You're a pharmacist? What do you do? Why aren't you calling from Walgreens? Nope. I don't work in a pharmacy. I don't dispense any product.
Yeah.
It's all clinical guidance and expertise. And I think that is something that EMS is realizing at this point, right?
Yeah.
That a pharmacist on the team can provide guidance in so many different areas. And I would say that especially over the last year, I have done a lot of clinical education around, chronic disease education, medication education, how things like COVID are going to impact MIH teams, et cetera. So there's a lot to be gained from having the pharmacist expertise. And as more teams recognize that, yeah, I think they're wondering the same thing, like, hold on a minute. Now, how can we do that?
I have this guy on my team, and I've tasked him with trying to set up the medicine synchronization, and I only do it when I feel guilty enough to try it again because it just doesn't work for us. Either I'm stupid or lazy or something. It just doesn't work for us. And so about every year I feel guilty and I kind of try it again. And this guy said to me, if I didn't know better, I would think someone's on purpose trying to sabotage this, because you talk to Mr. Smith and you have an hour meeting with them and you set everything up and do this. And then the next day he comes in to another pharmacist or team member wasn't working on him with this and asked for a refill that he wasn't supposed to, need for a certain amount of time. Do you ever walk out of these houses and say, oh, come on, Gladys, what the hell? We just talked about this yesterday and now you're doing this. Do you ever get really frustrated with people?
Well, sure. And I think sometimes, it's okay to call them on it a little bit,
yeah.
Right? And a big part of it is establishing a relationship that you can be real together as part of that patient-provider, trust. And so you're literally coming into their home, their safe place, and the trust level has to be really high there. And so establishing that relationship, really through evidence. Sometimes it takes 2 or 3 visits before that patient starts to warm up to you and
right.
want to listen to what you're saying. And sometimes it takes 2 months or 3 months before the patient wants to really listen to what you say. But yeah, so it is a balance of when to let that frustration show and when not to let it show, right?
Yeah. Sometimes they want a little kick maybe to get going.
Yeah. So, and we're not above that. Paramedics are real people, and they actually are probably more likely to be super real with a patient about what's going to happen if they don't, control their diabetes or control, their blood pressure or whatever it is. And I think there's beauty in that too, right? Is they are out there in the field and they see the worst of the worst, and they'll tell it like it is. And, I think that is another reason why it's beneficial, is it eliminates the barrier of the white coat, so to speak.
Because these paramedics, I mean, they see the worst, that when someone doesn't do something correctly and then they fall or whatever and truly have to go to the hospital, especially if they've taken this patient in before, or seen something bad happen because their habit wasn't up to par yet. So Victoria, when I was a kid, one of my goals was, when I got older, I wanted to ride on the back of a vehicle and just hold on for dear life. There's only two professions that do this now. There's the waste management people that still get to, hit the buttons and then step on the back of the truck and hold on. And firemen.
Yeah.
I don't really see myself being either of those, but I wonder if, well, I'm just going to come out and ask it. Have you ever ridden on the back of a truck just holding on?
Oh, yeah. I'm sure the teams would really view that as a liability reduction strategy.
You haven't done that with all this work?
No, of course not. I don't think so. We ride in an SUV. So it's not...
And you're not emergency. You're just going to...
It's not as cool. It's an emergency response vehicle. So if there is an emergency, you're the one you're going if you're the closest responding.
They're maybe in people's houses, and then they might get called right in the middle of one of these things, right?
Our teams do what we call self-dispatching. And so we have a schedule throughout the day. But sometimes there are breaks or intervals within that schedule in case a patient has an urgent issue and needs us to swing by, right? So so we specifically structure our day with some quote unquote downtime.
Sure.
And so, during that period of downtime, you will respond to 911 calls if you're the closest unit. So sometimes it's a really fun day. I will say that you never know what you're going to get. And sometimes it is, an incredibly traumatic day, depending on, right, what call you're going to.
And potentially, do they call you from a meeting? Like if you're meeting with somebody for whatever in their home and two dispatches are needed, one, let's say, from another car, do they ever pull the paramedics out of the house and say, look, we know you're having this meeting, but someone's having a heart attack a mile away?
Yeah, if there is not adequate, if there's not an adequate number of ambulances on the road to handle that, then yes.
But they don't plan on that. They don't plan that we're going to interrupt you a ton. It's not like this they just do to fill in dead time. It's like this is a primary purpose. They might use them for overflow.
Correct. Yeah. So you have your EMS stations, or for a fire-based system, your fire stations, structured all throughout your county, in each area of your county. The paramedicine program, or the mobile integrated health program, is additional and on top of that. And so they do not have the responsibility of covering for a specific zone.
Gotcha.
And so the only situation where they would be interrupted from a call is if for some reason you were on surge because every single one of your ambulances were dispatched on another call.
Yeah.
Or, if there was a situation where it was like the neighbor, right?
Yeah.
Like if you're at apartment A and the apartment upstairs, then of course you say, okay, we just got notice that your neighbor upstairs is having an issue. We're gonna go up there right now because we're the closest. So in that sort of situation, of course, they would pull you. But really your intention is not to cover the zone. Your intention is to be bonus.
So Victoria, what would be your coolest gig? Like right now, if someone's listening to this, who would be the coolest person to hear from? What would you like to do for them? And how would you like to get paid for that?
I think by far the thing I think would be the coolest right now is if you are, on the executive level in a health system and you are exploring how to launch a paramedicine program.
Which is going to save them money.
Tons of money, yeah.
And it's going to save, even like I was talking to a guest last week about Medicare Advantage stuff. It's going to save everybody a ton of money, right? Especially when these are repeat 911 people.
Yeah. So especially if you have a high percentage of uninsured patients, or if you're, being heavily dinged on readmissions within 30 days.
Don't hospitals say like, we will not turn you down for emergencies, things like that? Isn't that like the hospital oath or something? And don't people know that? And that's why they call 911 sometimes instead of setting up an appointment 43 days out with their doctor.
Yeah, absolutely. And they know that they're going to get care when they walk in there.
Especially if you put your hand over your heart.
Yeah, right? I have chest pain.
Oh, you get right in with that.
That's the truth, for sure.
You're like a movie star with that one. People come up and asking for your autograph and stuff. Well, it's not your autograph, it's your signature, but you pretend like it's your autograph.
It's your signature for care, yeah.
That's right.
So, I think that would be the coolest right now is, if you're trying to figure out how to create a robust disease management program with a local EMS entity or a fire entity, or even if you're trying to create a hospital-based program, then I think that, I definitely, this is like a dream. I would love to do that.
You'd like for them to call you.
Yeah. Find me on LinkedIn.
You're going to travel there for a few days and have meetings. What are you going to do with this place once they call you?
Yeah, so we would set up, virtual meetings, because there's really no sense in the expenditures on either party's side of going in person at this point until they're actually, able to define where their biggest pain points are, what type of program they want. So there's a variety of questions that need to be answered to start. And there's the concept of, we need the data to show what numbers you want to move and where you need the change. And then once we look at those numbers and we start to look at the resources in the area from an EMS standpoint, then we start to put together what it would look like for a program. And that's when I probably would travel to meet in person to really meet the team members that we would be working with in establishing this program.
What is your financial picture? And do you have different levels of things? Are you working just as the consultant? Are you working on individual parts of this? Where are you? Where do you want to go if you're not there yet?
Yeah, so there's three different ways that teams can hire me to, provide services for them in some way. So number one is clinical education for your team. And so that could look like, a couple hours of clinical education in a specific area, or it could look like regular, consistent clinical education throughout the year, in which case that would look like, payment on retainer for continued education based on whatever comes up within your team. So in that setting, it looks like, really understanding the team, becoming familiar with the clientele of the team, the types of patients you have, and the program goals that your team is working every day to achieve, and then coming up with tailored education specifically for paramedics in these niche areas that will empower your medics in the field to know what to do when certain clinical situations arise.
What's an example of something that you would be teaching them pharmacist-wise that they don't know already from assessment-wise?
Just as an example, in the last month, some of the education that I've provided is, number one, how to do a medication reconciliation.
Oh, okay.
So there are structured stepwise approach, logistics within that. In this particular situation, you would have paramedics that are doing medication reconciliation in the home after hospital discharge. Another example is understanding like your top 5 medicines for heart failure and what they're doing, and, should a patient be taking furosemide every day, or what does a heart failure management protocol for fluid management look like on the outpatient side? Things like at what level of weight gain should the patient be contacting their physician?
Come on. You guys are always bringing up weight gain on these. I think all my guests get together and throw that in for like a intervention. So... But what just came to me, though, is that you're not teaching about like what happens with an overdose on these top 5 medicines. No, they already, well, not that you would overdose on some of those, but they already know that. You're teaching them like how to keep somebody home on this. Like, let's look for side effects that might be problematic, and what can be done with conversations versus saying, oh, this person's whatever, holding on to fluids, let's take him to the ER or something like that.
Yes, correct. Yeah.
All right, so that's one level.
Yep.
And then you mentioned 3.
Yeah. So the second level is consulting for programs who are developing what their protocols should be, or, for programs that want some sort of evaluation, of how well they're doing in specific areas, or if they know that they are struggling to, capture outcomes data with their current EHR, their current software, and they're trying to figure out, how do we build that in? What does that look like? Which metrics do we need to track? Those sorts of pieces. Those are all examples of different consulting services that they could bring me on. And that is done typically on project based, depending on how many hours and the length of time commitment for helping them tackle that from, beginning conceptualization to the end, which could be anything from, a write-up of an evaluation of their program to, working side by side with them every week to update and implement, new EHRs or softwares. And so that's the second phase, is some sort of consultation for program development or evaluation. And then the third piece is actual direct patient care. And so that would look like, something small scale, which would be, we would like a pharmacist to review our top 5 most medically complex patients every week. Or it could be,
I gotcha.
Yep. Or it could be full scale, where they actually implement a pharmacist. And in that case, they would be hiring me to train their pharmacist and place the pharmacist in their location.
In your 3 levels there, which one of those was like a blind executive saying, we need to get this going because we need to save money somehow?
That is all 3 levels combined.
Oh, I gotcha. Those are all parts of that.
Yep. So I would do the consulting piece around how to develop the program, connecting with the existing resources, working with the EMS teams, working with the hospital teams. And I would be helping provide the training. So it would include the clinical education piece, and also incorporating a pharmacist in whatever way, shape, or form they wanted. So if they wanted to use their own pharmacist, then I would train that pharmacist for this unique role. And if they wanted to have a pharmacist brought in and staffed separately, then I would do that.
And asking that question, I always forget that there's work involved sometimes. I wanted a level just where I could sit back and say, here's what you should do. Here's my idea, and I'll pay me for it. I mean, they can listen to this and say, yeah, that sounds good. But where it comes down to is getting it done, getting things set up, the right people, the right process, and all that kind of stuff.
Yeah. And, it is an investment, right? And so I think that it goes back to one of the biggest issues in this concept of mobile health is funding. Is who wants to pay for something proactively to save money in the long run. And that's again, not the philosophy of our current health system, but we do know that it's worth it. And so if anybody is listening and you're ready to shake it up and you're ready to do things through what we definitely foresee as being the future of healthcare, then yeah, I'm your lady.
I only have 3 listeners per episode. I listen to it. Next week's guest listens to it to see how much of an asshole I am to them. And then my dog, I force her to listen to it.
We did say my patients from Sarasota are listening, right?
No, they're not listening. That's why I gave you freedom to talk about their gaudy rings and putting their purse on the counter and knocking all the crap over. So, Victoria, what do you want to be doing in 5 years? Tell me what your week looks like, business-wise.
In 5 years, I will admit that in some ways I hate this question. And I'll be honest about it, because I will say, and for anybody that's listening, this is advice I would give as well. I have gotten to where I have gotten because I said yes to strange opportunities and situations where, there was a door that started to open, and I said, do I want to walk through that door though? Do I want to say yes to that? and it has been really rewarding for me. Right. So, I would have not gotten my faculty role if I hadn't have said yes to being a keynote speaker at an event. And I would not have discovered paramedicine if I didn't say yes. On top of all my other responsibilities, I'll come in and do some consulting for you about this grant and how to figure out the med management piece. And, I think that saying yes to things that you're not sure that you're going to like is how to get a lot of really amazing opportunities. And that's what happened to me. And so when you say, where do you want to be in 5 years? I don't know. I could say yes to something tomorrow that completely changes, the course of what I want to end up doing, or could open, a fourth branch of my business.
Yeah.
I don't totally know. But if, again, in the dream world, I would be working with health systems to partner them with paramedicine teams. I would be establishing pharmacists within paramedicine teams across the nation. I would have, clinical education that is being provided regularly from my company, from my business to EMS teams. I feel like I definitely want at least one day a week that is direct patient care, direct education. You said in the beginning,
Are you serious?
Yes. You said, what are you? Are you a teacher? Are you a businesswoman? Are you a pharmacist? And the truth is that I'm all of those. And I love teaching. I love it. And I love helping people. And I also feel that having some direct patient care really does keep me rooted in what my patient population, my incredibly vulnerable, disadvantaged, socioeconomically disadvantaged patient population is dealing with. And so I would still want to have at least one day a week where I have some sort of teaching, lecturing, or direct patient care, or on the boots, working with a team in some way to help, directly resolve their problems.
Dealing with individual people in their home. Would that be okay for teaching, or do you want to teach a bigger multitude?
I don't think it's too small. I think that you still have the ability to gain from that.
For you to gain from it, actually.
Yeah. So, obviously the patient will benefit, right? There's value there to the patient. But I continue to ensure that I am fresh, and that I am capable, and that I'm learning about whatever my individual patient is dealing with, right? I think that, so to put it in perspective, so right now, I still have my faculty role. I'm running my own business. I'm a mom of 2 crazy girls.
Good looking kids, by the way. I saw them online.
Thank you. Thank you. They are sass. They are sassy. They're great though. They're great. So I have a lot of different things that I'm doing. But do you know what I'm doing 2 days next week? I'm vaccinating.
Oh.
Like, I'm going into the hospital. I'm working a vaccination shift because it really does help me completely understand, all right, so when somebody wants to hire me for a vaccination program, next month, I have seen the struggles with registration. Yes. I have seen the struggles with physical space and how the layout of a clinic or the logistics of an operation goes.
Yeah.
I have
firsthand.
And so I am able to, through doing something firsthand, I am still able to identify where the gaps are that we are not meeting or where teams are not efficient.
It's not like you have to do a 70-hour week doing that. You can just pop in for a day and do it.
Right.
All right, here's the other extreme. What would it be like to only work with employees? And I don't mean pharmacists. I mean other trainers. Let's say that this grows and you've got like a bunch of people like you, not as talented because you're the head honcho. So if they're as talented, they should go do their own thing, but very close. What if you only could talk to them? Would that drive you crazy? Would you still need some, like, all the interaction you talked about? Because some people dream of that. They dream of being in a situation where they're only talking to their employees, not talking to any customers. But do you think you'd still like to be, like, talking to these C-suite people at the hospitals are doing this, or you're like, fine, let someone else do all that?
No, I feel like I am most comfortable in my own brain being an ideas person and switching it up and discussing new ways to do things and figuring out how we can be more efficient and
With employees.
yeah, but with employees, you're in a teaching role.
That's true.
Right? So anytime you have somebody that works for you or works within your business, or you're the lead on helping them to see the best way to execute a project, then you're in a teaching role.
Yeah.
Right? So if you're working with an employee, you're teaching. Or you should be, or you're doing it wrong.
Yeah.
Right? I think I'm just one person. That's my thought. If you're working with an employee and they're not gaining something out of their time with you, a new perspective, a different way to do things, guidance or instruction.
Yeah, you're teaching them.
Yeah. Feedback on how they could be doing something better. Learning about a new venture that the business is doing, or a new way that healthcare professionals are being evaluated and ABC measures, they're learning from you in some way, hopefully, or we're doing it wrong.
Let's say you're at the level where you could only teach your employees. You're not going to Mrs. Smith's house. You're not doing any vaccinating. You're not talking remotely to some pharmacist somewhere. You're only talking to your employees. Would that drive you crazy? Or you think you'd want some outside stuff still too?
Yeah, because then, I need to be learning too.
Yeah.
And I need to be growing. And I'm not saying that you can't learn an incredible amount from your employees.
Right.
But their job is not to teach me about things or help me develop. That's my job, to help them develop.
So you're going to get that full circle by going around to somebody else.
Being in a position where the majority of your role is working with employees, helping them execute projects or oversee departments. And, I think there's a lot to be gained from that. But I think that, networking, going to conferences, learning new ways of doing things myself, shadowing different teams and figuring out, what's a different approach to how this model of care can be done. I feel like all of those pieces, help me develop personally.
Well, Victoria, what a pleasure having you on.
Oh, thanks so much. I've enjoyed chatting so much.
Yeah, likewise. Best wishes on things. Everything you're saying was really cool. It made a lot of sense, but especially like that 4-to-1 payoff. It's like a no-brainer to get that going.
Yeah, thank you. I'm hopeful as well. And I know that, as this method of care expands across the nation, that more and more teams are going to need people that have experience navigating from the health system to the EMS side.
For sure. Very cool. All right, Victoria, take care.
Thanks so much.
All right. Thank you. Bye-bye.